Thank you very much, Ritu. And next I'd like to ask Brent Magner to join us. Brent is from the American Board of Radiology, the American Institute of Radiologic Pathology, and also a community radiologist in Pennsylvania. I may ask, Brent, if you don't mind, we're running a bit behind, and it's not fair of me to have you do this on the fly, but as much as there may be overlap with the pathologists, maybe just push on to the next important stuff.
Absolutely.
Thank you.
Thanks, Jim. And I was thinking exactly the same thing because Ritu covered an awful lot of the material that I'll cover, so it's going to be easy both for me and for the audience, I think, because some of the themes you're going to see again. It's an honor to be here and welcome. I welcome the opportunity to share this information and learn from each other. These are some very real challenges that we're all dealing with. My disclosure, I have no financial disclosures relevant to this presentation. I'm an unpaid volunteer with the American Board of Radiology. The slide at the lower right, the part of the picture at the lower right is just to remind you that I am in private practice. And it's not Peoria, but it's close. It's in southeastern Pennsylvania, and it's the Peoria of eastern Pennsylvania. This is Reading, Pennsylvania, a community of about 400,000 people in our primary service area. But that's the busiest emergency room in Pennsylvania. In fact, it's about the 9th busiest single-site emergency room in the country. I know because I worked yesterday, and it was busy. So that's my day job, is private practice radiology. I also have a background with the the Armed Forces Institute of Pathology, although most of my tenure there, I was neither in the Armed Forces nor, of course, am I a pathologist. As a result, they buried us in the 2 floors down from ground level in that back building, the one with no windows. It's an architectural masterpiece. It's beautiful. We had to walk through blast doors, believe it or not, because it's a converted bomb shelter that they made into a building for pathologists and radiologists. And then they put the radiologists 2 stories below ground just to make it clear what our place was. But we did learn a lot of pathology. And I still lecture as part of the successor course to that, which is the American Institute of Radiologic Pathology, which is a subsidiary of the American College of Radiology. So on Wednesday, I'll be lecturing to a couple of hundred radiology residents on the concepts that bring together radiology and pathology. So all that said, I'm here to talk really from the perspective of the American Board of Radiology. I have a very similar disclosure because we're told by sort of the office staff in Tucson, tell them everything is changeable, and in fact it is changeable, but most of this is pretty standard. Our mission statement, I hope we don't have to change it again. It took us 3 days to get to that. 20 people in a room, 3 days, and this is what we came up with. But it's important to define the disciplines right out of the chute. What does it mean to talk about disciplines? We have 4 different disciplines in radiology. For today's purposes, diagnostic radiology is what we're really interested in. That's about diagnosis. The others, though, are part of the American Board of Radiology. And the other word was patients. The first draft of this didn't have the word patients in it. And I really had to stress the idea, and you mentioned public, more or less the same thing. This does not exist for radiologists. The American Board of Radiology exists for patients. This is not about serving doctors. This is about serving the patients, and we do that by testing and certifying that they have the requisite knowledge, skill, and understanding of the discipline to serve the patients. And I may come back to that mission statement as we go through this. So we, too, have 3 components to our exam: the core, the certifying, and the continuous or maintenance of certification. And I can go through this quickly because much of it overlaps with what we just heard about pathology. The core exam has 12, and it depends on how you count them, as many as 15 or 18 content areas. We administer at the end of 3 years of residency, and because an internship is required, it's actually between PG4 and PG5. And if you don't pass this, you can't proceed to the remaining part of certification. So this is part 1, if you will, to getting to a board certification status. And these categories are listed here. They include organ systems, modalities, and then fundamentals that really cross over all of these lines. And you'll see that depending on how you choose to count them, again, you can get to about 18. And that generated the grid, the infamous grid that we use to design the exam. And the reason the grid exists, and the reason I show it here, is that we're trying to get a broad coverage of all the sort of required elements that would make a diagnostic radiologist. And the psychometricians, the people who tell us how to do tests, tell us that we need 60 in every row and 60 in every column, meaning 60 test items. As a result, we have an exam that has well over 600 questions And I can assure you the residents do not find it pleasant to come to a test center and sit for 2 half days in order to get through this. But at the end of it, we feel we have covered the domain of diagnostic radiology, and that's what's important at that level, at that very first stage. The questions look something like this. So we'd show them a chest radiograph or a CT scan or an MRI. We ask a multiple choice question, pick the best diagnosis, and probably 85% of our questions are exactly like this. Just asking you to get to the correct diagnosis based on an image. And again, this is after 3 years of radiology residency plus 1 year of internship. Here we are designing the core exam. It takes us 3.5 days. Now, this is after the items have already been made. We have thousands of items, and we're trying to fill in that grid to cover that domain of what makes a diagnostic radiologist. I can assure you it's a lot more interesting than it looks. But the first 2 days are pleasant. The last day and a half, you just want to run through one of those windows and throw yourself out because... Actually, I learn something every time I do this. It's a wonderful experience, but it's despite all that effort, we still get criticism that the test is not only not relevant, but inaccurate. In any event, if you pass the core exam, you wind up in the certifying exam. The candidates now select specific areas, and this gets us back to this idea of sub-specialization. Now they can pick clinical practice areas. And those clinical practice areas really look an awful lot like those 12, but you could eliminate things. So you could say, well, I don't intend to really spend much of my time doing musculoskeletal imaging, but I do a lot of body imaging, so I'll take 3 areas. I'll take chest, abdomen, or chest, GI, and GU in order to get to that. And the certifying exam is given actually after completion of residency and or fellowship. And at that point, again, you're starting to subspecialize because you're picking areas that you really think are going to comprise your practice moving forward based on your training and interest. And that gets us to the continuous or maintenance of certification. And this includes, as Ritu mentioned, enhanced CME and professional quality improvement or practice quality improvement activities as part of this, but I really wanted to concentrate on the exam. And we, too, had an every 10-year exam that we just did away with, and we did it for a couple of reasons. One is that we realized that if you take a test, and I did this, I showed up and I took my test as it was required. It was 10 years, and that would buy me another 10 years. The problem is we don't know what happens to that radiologist in that 10-year period. We know what they were like on that day. The second problem, this is a bigger deal, was there was no feedback back to that resident, that candidate. So I took the test. I was a member of the American Board of Radiology. I took the test. I got 0 feedback. All I know is I passed. And I don't know what were my strengths, what were my weaknesses. None of that was available. So it was a flawed, really a flawed exam, if you will. And we ceased giving that for practicality about a year ago. And in January of 2019, we're going to transition to a longitudinal lifelong assessment. Now, this is sort of a hybrid of what we just heard about with pathology, but this will count for the 10-year exam, meaning that you're going to get 2 questions a week by email. And when you answer, we're going to give you immediate feedback. Did you get right? Did you get wrong? Where are your areas of strengths and weaknesses? At the same time, though, it is a summative process. That's psychometrician talk for, it's a test, and you got to pass. You don't have to get them all right. But if you get enough of them wrong, we're going to have to bring you back and say, okay, you have to formally test now at our test center. So we expect to get this going in January of 2019. We're going to pilot it later this year. And this is important because it allows an opportunity to start to get to some other nuances around subspecialization. So this is similar to other certification boards. In addition to what pathology is doing, anesthesia and pediatrics have already started this. The ABR version is going to allow us to, again, select a practice profile content. So it'll be very similar to that certifying exam that allowed you to kind of say, this is where my practice is, this is where my training and experience are. You can even fine tune it beyond that because you're going to be able to decline to answer questions that really have nothing to do with your practice environment. Now, what that does effectively is it increases the number of questions that are built around your practice environment, because when you decline to answer one question, we're going to give you another one. So, for example, if I said, I don't do MRI of the knee, then I'm going to get a question on renal tumors, which is something that I do. So, but more important than that, it creates a future state. And this is why I was excited to come to this panel and talk about what we could do. And oncology and emergency radiology were things we talked about a year ago as areas that we were hearing from our diplomates kind of saying, it's all well and good that you're testing me in body imaging, but if I'm mostly an ER radiologist, most of my time is spent doing emergency radiology, and you're testing me on staging a renal carcinoma, you're really not helping the patient. Remember, that was what it was all about, was the patient, nor you're really being relevant to that individual's practice. Now, the flip side of that, of course, is if you're involved mostly in cancer imaging, and I'm showing you a dissection of the thoracic aorta in an acute person who was in a car accident, that's not helpful either. That's neither helpful to that set of patients, nor is it helpful to that candidate in the test. So it does give us an opportunity, I think, to do this. And as Jim said, in the interest of time, I'll just run through this very quickly. We really were trying to get to the idea of the clinical outcome, the relationship that one sees, but more importantly, can we be relevant? Can we make it valuable to the diplomates so that they feel that this process, which again is both formative, that is, it's an educational process, it's also summative, we're trying to live up to our obligation to the public at the same time. So, and I'll just run through this, that the MOC process really is built around this self-assessment and lifelong learning, and we're hopeful that this new process, which should allow us to fine-tune and get at, what does your practice actually look like, and start to talk about specifically oncologic imaging or whatever your practice consists of, and make it defined around what are the things that you actually do, what can we do to enhance the validity of this certificate for the patients that you serve. And again, I'll go through this quickly. This is actually a graphic. It looks an awful lot like the Modigliani-Miller equation for those of you with finance background. It has nothing to do with that. I swear I wrote it on the back of a napkin before I even knew that equation exists. And this is about acceptability and difficulty. And just to look at these three curves, the red line is sort of that radiologist you don't want to visit, because to them, the harder the process of continuous certification, the less they want to do it. So that's a radiologist, you don't want to deal with them either in your work environment nor as a patient. The gold line is what the patient would want. This is reasonable, meaning the harder the process is, the more acceptable it is to the patient. I would argue the white line is kind of those of us who realistically, this was alluded to already, how much can you really ask of a practitioner? We want them to take this very seriously. We want them to learn what they need to know to be relevant and useful to their patients. And I would argue there's a sweet spot there. And beyond that, we start to lose people because you're just asking too much of people to be experts at everything. So with that in mind, again, it started at the back of a napkin. The message is that the value of our board certification, whether we're talking continuing certification or maintenance certification, it goes by both names right now, is proportional to how rigorous that process is. We don't have the opportunity to be self-regulating unless we do it well, and we're trying to be relevant and reasonable. And I'll just leave you with the two take-home points. We're trying to uphold that rigor of the board certification process. And then beyond that, we're really excited by this new longitudinal assessment, both the formative function and the summative function, but also the idea that we can start to really hit that sweet spot of, are we being relevant to that individual practice and best serving the patients that that individual will be responsible for? Thank you very much for your attention. I went there pretty fast. Thank you.